morning, Mr. Vice Chancellor, in absentia, represented by the DBC Academic, and thank you for coming for this lecture. Evolution of treatment for chronic myelogenous leukemia in Nigeria. The Vice Chancellor, Deputy Vice Chancellors, the Chief Medical Director, the Registrar, the Bursar, College Provost, Deans of Faculties, represented by the Chairman Committee of Deans, Senate members here present, heads of department, distinguished ladies and gentlemen. Please allow me to warmly welcome you to this valedictory lecture, being delivered today, Thursday, 31st March 2022. This lecture should have come up on Saturday, 2nd April, my 78th birthday, which falls on the first day of Ramadan, a period many of us cannot entertain guests in the daytime, hence the shift. So do accept my apologies and thank you for honoring the invitation. I chose to talk on evolution of treatment for chronic myelogenous leukemia, otherwise called CML, in Nigeria, based on my rather disappointing experiences managing hematological malignancies in a disadvantaged setting, and how chance do sometimes influence our decisions. I joined the services of the university, then the University of Ife, on Monday, 2nd June 1986, during the period of the implementation of the structural adjustment program in the country. Based on the several unpleasant experiences at that period, the title of a manuscript I was preparing, that is Cancer Management in Ife, from 1986 to 1991, had to be altered to Management of Cancer under Structural Adjustment Program. I recollect how most of our patients, including a 12-year-old girl, with CML, who lived long enough to become a Part 2 student in chemistry in this university, and who was just about to travel abroad for bone marrow transplantation, had to abort the trip because of the SAP-related sudden astronomical rise in the foreign exchange rate. Regrettably, we lost her in her third year. In 1993 publication with Professor Julius Faluyi of Botany Department on chromosomal aberrations in Nigerians with hematological malignancies gave Ife the opportunity to coordinate the first national study on chronic myeloid leukemia on interferon alpha trial. The study prepared us for the ongoing nationwide treatment of CML with the novel drug Gleevec and other tyrosine kinase inhibitors, and hence the title of today's lecture, Evolution of Treatment for Chronic Myeloid Leukemia in Nigeria. Chronic myelogenous leukemia is the commonest of the leukemic myeloproliferative cancers, and the first known malignancy to be associated with a unique acquired genetic disorder, a reciprocal translocation between chromosomes number 9 and 22, leading to generation of the diagnostic Philadelphia chromosome. The mutation transfers the ABL tyrosine kinase gene on chromosome number 9 to the breakpoint cluster region on chromosome 22 to generate the oncogenic BCR-ABL1 fusion gene that induces malignant change and development of the leukemia. Hitherto, CML was an almost incurable cancer with the following notorious characteristics. 80% chance of dying in 2 years, 10% chance of dying within 6 months, 10% chance of living to 10 years. Nobody lived beyond 10 years, and there is no cure. Outside a successful stem cell transplantation, which is available to less than 45% of affected patients, there has been no reliable, potentially curative treatment until the arrival of this magic drug, Gleevec or imatinib, and allied tyrosine kinase inhibitors, a group of highly expensive, lifelong targeted medication. Treatment modalities previously used in Nigeria included chemotherapy such as cyclophosphamide, busulfan, doxyria, and interferon alpha. Prelude. The lecture will discuss briefly epidemiology of CML, core laboratory diagnosis, evolution of CML treatment in Nigeria, goals of imatinib treatment for CML. We will also talk on challenges of Gleevec therapy in Nigeria with reference to adherence to therapy, pharmacokinetic studies, second, third generation tyrosine kinase inhibitors, pregnancy and Gleevec under COVID-19 lockdown, and survival studies. Mr. Vice Chancellor and my dear guest, etiological factors for CML include exposure to radiation, smoking, obesity, and occupational exposure to benzene, and treatment with DNA topoisomerase inhibitors, such as etoposide. The global incidence for the leukemia is 1 to 2 per 100,000 of the population, with a slight male predominance. Age at presentation in the Western nation is around 60 years, compared to the median age of 30 to 40 years in the low and middle income countries of Asia, Africa, Latin America, Southern and Eastern Europe. CML is rare in children 18 years and below. The median age of the 1,550 cohort of Philadelphia chromosome-positive CML Nigerians accessing imatinib in the country was only 38 years, with male-female ratio of 1.5 to 1, and very few of them, just 10%, were over 60 years and above, as previously reported by Professor Fleming in 1993. How do we make the diagnosis of this disease? In addition to the clinical features and elevated mature granulocyte counts, including basophilia and normal to raised platelet count, confirmatory diagnostics include positive Philadelphia chromosome due to translocation between chromosomes 9 and 22 from bone marrow karyotype, as earlier said, and or positive BCR ABL transcripts in blood of the patients, evaluated by molecular transcripts, including PCR and of fluorescent in situ hybridization fish. Periodic assessment of the PH chromosome and the BCR ABL transcripts are also used for monitoring disease response to treatment and confirmation of minimal residual disease. This figure shows the karyotype of a female patient with Philadelphia chromosome. You can see the arrow from chromosome 22 being transferred to the lower section of the one of chromosomes number 9. That is the shorter arm, the shorter chromosome 22 is the Philadelphia chromosome. A number of substances, including chemicals and radiation, were used as palliative treatment for CML from about mid-19th century, with some disease amelioration, but never evidence of curability. Palliative agents used included arsenic trioxide from about 1865 and splenic irradiation from 1903. Standard chemotherapy, including busulfan and hydroxyurea, were introduced in 1953 and 1972 respectively. And autologous bone marrow transplantation started as a palliative care in 1978 and soon graduated to become an upfront curative therapy in 1982 with the introduction of HLA-compatible match-related or match-unrelated donor allogeneic marrow transplantation. Recombinant human alpha interferon was introduced in 1980s as a potential cure for CML, in particular for patients ineligible for marrow transplantation. The ultimate definitive therapy came at the end of the last century with the discovery of a small molecule, the STI 571 compound, by Dr. Brian Drucker, a cancer research professor at the Oregon Health and Science University in USA, as shown in figure 2. This figure shows the beginning of CML therapy. You can see in that figure that before 1845, there was no therapy. Then started arsenic trial, splenic irradiation, busulfan, hydroxyurea, and by 1978, bone marrow transplantation, interferon alpha by the 80s, and from 1998, the beginning of what we are discussing today, imatinib therapy. Between 1986 and 1999, we managed 42 patients with CML, 27 males and 15 females, aged 12 to 74, median 38 years. 5 were karyotyped and confirmed positive for Philadelphia chromosome. 33, 7, and 2 presented in chronic phase, accelerated phase, and the untreatable blastic phase, respectively. Patients were treated with busulfan or cyclophosphamide only. Even then, therapy compliance was subnormal. Median survival for patients in chronic phase was only 31.7 months, shorter than the 43 months recorded for richer countries that were similarly treated. Only 5 of the 42 patients, of the 15 chronic phase patients, survived up to 60 months and above, compared to over 50% reported in the more advanced nations. The use of recombinant human interferon alpha and CML in Nigeria. Recombinant human interferon alpha was introduced in the 80s as the second breakthrough for possible cure of the disease. Interferon had achieved complete cytogenetic response in about 20 to 27% of patients with chronic phase disease and a 10-year survival of 78%. Improved survival was achieved with the addition of cytosine arabinocyte. From 1996 to 1998, Ife coordinated the only interferon trial on the efficacy and safety of the immunomodulator as a monotherapy in 17 consenting male and female patients, CML. Mean age, 34.5 plus or minus 10.6 years, presenting in early chronic phase. The drug was administered subcutaneously at a maintenance dose of 9 million international units daily for 12 months. Drug efficacy was evaluated by assessing both hematologic and cytogenetic responses. Tolerability by the incidence of adverse events, and safety by hematologic and biochemical indices. 6 patients, 54.4%, achieved complete hematologic remission, and 3 others underwent partial cytogenetic remission. Drug-related adverse events were seen in 70% of the patients, and severe depression was reported in 1 patient. Unfortunately, because of our poverty, this trial could not last longer than 12 months, because then the treatment for 1 year was as high as 1 million naira, which was big money then. Gleevec and CML in Nigeria since 2003. Gleevec is the first anti-cancer drug specifically targeting the active kinase ABC leukemia viral oncogene formula 1 of the BCR-ABL chimeric gene. This tyrosine kinase inhibitor has the capability to induce hematologic remission, eradicate the Ph positive cells, the BCR-ABL transcripts, and prolong survival while sparing the surrounding apparently normal cells. What we are saying here is that Gleevec is a specific drug, it's a targeted drug. Once you have identified the molecular basis of the cancer. So this drug was then designed to target the abnormal gene. That was what the previous therapies could not do, except bone marrow transplantation that was not available to a large majority of the patients. Clinical trials were conducted on STI 571 from 1988 on volunteers living with the cancer. The drug was granted accelerated approval by the USA FDA in 2001. The approved molecule is currently being marketed by Novartis Pharma as imatinib. Figure 3 shows the picture of 3 of the participants in the STI 571 trial of 1978. From the left, we have Doradine, 79 years old, the longest survivor on CML since the onset of the imatinib trial. She has been living for CML, with CML since the past 25 years. So this is almost normal survivor. In the middle, we have Don Jensen, 83 years old, CML since 1997. Then far right, we have Judy Orem, 73. She was diagnosed in 1995. Interestingly, all these 3 patients were initially on alpha interferon. So the moment Gleevec was discovered, they moved onto Gleevec, and that is why they are still surviving. Gleevec and CML in Nigeria. What are the goals of using this drug in our patients? These are to achieve complete hematologic remission within 1 to 3 months of starting imatinib therapy. Complete hematologic remission means restoration of their normal status to the levels we are currently on, myself and yourself. Achieve complete cytogenetic response, that is, the abnormal chromosome, Philadelphia chromosome, is 0%. Because if you are able to remove that, CML will disappear within 6 months of therapy. Major molecular response, that is the BCR-ABL chimeric gene, should be less than 0.1% by 12 months of therapy. If you are able to achieve this, you are likely to undergo deep molecular response, that is BCR-ABL less than 0.01%, and complete molecular remission, that is BCR-ABL less than 0.001, and